all of you this morning. It's a real honor and privilege to catch up with old friends and meet new ones, and to have this engagement. So Tian, I'm going to dive right in, and I was given 6 questions as a guide for the conversation. And I'm not sure how you want to take it. I could just, run through very quickly, like an overview, and then take questions. They are actually in sections.
Great.
So the first was just, CAPRISA's current research portfolio. The second is how COVID-19 has impacted the CAPRISA work. And then the third one was about what you think advocates should be having at the top of their mind as we build solidarity and respond to COVID-19. And then it's about what do I think is the most promising study currently being undertaken in terms of COVID-19 and why. And then the top 3 things as we move forward. So there's a bit of overlap between what you should be thinking about in the top 3. I'm taking that as a kind of prioritization and probably merge that. And then, so as a quick reminder to most people, CAPRISA is a fully self-funded organization, and its funding is obtained from competitive grant applications. So the overarching goal, if you like, is to undertake locally relevant and globally important research that impacts HIV and TB. And since inception in 2002, we really focused on 2 questions. The first is, how do we prevent HIV infection in young women? And 2 is, how do we reduce mortality rates from people who are co-infected with HIV and TB? And if we look at the global statistics, we still continue to see 1.7 million new infections, as we know from the Global 2020 report, in contrast to the 500,000 new infection target we should have had at this stage. And secondly, as we think about the 3 zeros goal of the UN emanating from the UN high-level meeting, we're still seeing more deaths, even though we have initiated large numbers of people on treatment. There's still big gaps, and that is in spite and despite the treatment scale-up that we've seen in the past decade, we still see about 800,000 deaths occurring. And we have a growing number of people living, thankfully, with AIDS and transforming that into a chronic manageable condition. But at the same time, with the cohorts aging, there are a whole lot of new issues and challenges that we start to see and experience. So that's a sort of global context. And if we take that 1.7 million new HIV infections or the deaths, the majority are still occurring in sub-Saharan Africa, and notably in Southern and Eastern Africa. And so the questions we set out to ask, while we've made some contributions in the past that I'm quite happy to share with through publications to date, but these remain challenges, and we've made some incremental advances. But we're far from having answered both those questions. So in the interest of time, I'm going to focus on the HIV prevention portfolio. So when we think about research in CAPRISA, we have a balance between CAPRISA-initiated research, where CAPRISA scientists ask the research questions, lead that. But we're also good citizens, and we participate in multi-center studies, and that's primarily through the NIH-funded prevention and treatment networks. That includes IMPACT, that does the perinatal work, the prevention trials network, the vaccine trials network, and sometimes and until recently, prior to the closure of the microbicide trials network, we're also doing work with the MTN. And I'm going to really highlight our work because I think the multi-center NIAID-funded work is available through those network websites. And whatever I'm going to present to you, you can also access in terms of CAPRISA-led work through the CAPRISA website, which is www.caprisa.org. We post all of our new publications there. We also post new studies that we're doing. So I'm going to really be very focused in terms of what I share for this with this group. So in terms of prevention of infection in young women, there are three components to the work. They're interrelated, but the three key areas is about who is infecting who. Two, why are young women so vulnerable? And we know the stats of 18 to 24 years, 15 to 24-year-old women having up to 6 to 8 times more infection compared to their male peers. We've done that cycle of transmission. And so there's both behavior and biology, and in the why, we're trying to understand those aspects. And the third is, in parallel, what do we do about reducing the burden of infection in young women? And so, as I said, if I had the whole day, I'll include the TB work, but maybe that could be part of another conversation. So in terms of who is infecting who, in 2016, we shared at the International AIDS Conference in Durban, the cycle of transmission that showed using state-of-the-art technology and phylogenetics, which involves sequencing of viruses, that how is the virus spreading? And it's very clear from that work that men 25 to 40 years are infecting young women, 15 to 24 years rather, who in turn, as they, if they reach, because quite often we don't talk about the mortality rates in 15 to 24-year-old women when we focus on prevention. So just a reminder, should they be so fortunate to reach 25 to 35, in their peer interactions with males, 25 to 40, they infecting, and so the cycle of transmission continues. And so one of the things that work did was initiated a program in KZN led by one of the members of the royal family called Isibaya Samadota, which is about men working together and taking responsibility. And the program was really targeted at reaching men 25 to 40, getting them to test and, if positive, to be initiated on treatment. And it was done very closely with the Provincial Department of Health, and filling the gaps. For example, they were reaching the men, they were getting the men to test, then there were delays in initiating them on treatment, so that led to mobile services being provided. And what we do is, as part of the who is infecting who, we have to ensure that we on top of what's going on with the epidemic. And so epidemiological study that we do is a population-based survey that was done repeatedly several years apart. And so we were able in that surveillance program to be able to measure the impact of Isibaya Samadota and what was the impact of the increase in testing and treatment linkages for men 25 to 40 on young women 15 to 24 years. And that paper has been published in the Lancet, and I'm quite happy to share the paper with you all, a synopsis of it. In short, what we found was that the incidence rates in men 25 to 35, who were largely the group reached, escalates very rapidly. And so newly infected, their viral loads are very high, and prior to them being initiated on treatment and virally suppressed, they're having concurrent relationships with women over 25 and women under 25. And so there are high transmission rates there. But when the men are initiated on treatment and virally suppressed, it has a substantive impact on young women under 25 years of age. So it feeds in, and as you will be aware, a lot of our focus in trying to end AIDS as a public health threat has been on 90-90-90 as part of the UNAIDS fast track strategy. And the three large trials that we done, the NRA study, the POP-ART search, and the fourth study in Botswana, have actually shown very little population level impact on incidence rates, despite the very compelling HPTN 052 data about individual level impacts, that if you initiate individuals on treatment early, it will prevent infection. And I think that this impact assessment on Isibaya Samadota, together with the EPI study, has highlighted for us the importance of understanding the epidemic at a local level, understanding what's driving infection, and then putting together a combination of interventions that targets the strategically the populations that you need to in order to see that impact. And so this is in one district in KZN. It is one of the higher burden districts, but as you know, in KZN, 7 out of the 11 health districts are in the top 12 districts in terms of high disease burden. So that's the first bit around who that you may have not seen or known, and how that ties into our overall goals in terms of the 3 zeros and progress to that, and how it ties into other research and why we may or may not have seen impacts that we anticipated. And I think it does underscore that this is not a magic bullet, single thing. You know, it's 90-90-90 is not going to solve everything, but you know, we need to understand vulnerability, vulnerable populations, and we need to be much more localized in our understanding of the epidemic and how we respond. And some people think, but you know, what's the thing we need to do? So I think it's a reminder, it's not a thing, it's a complex intersection of many factors, and that if you want to make an impact, you have to think a lot more smartly and strategically in how you design and target your interventions, how you monitor that, and how do you measure impact. So in terms of why, I think we are all familiar, or should be, with our findings on genital inflammation and how genital inflammation enhances HIV acquisition, and 2, how it also reduces the potency of tenofovir gel. And so our ongoing work in that space in terms of trying to understand mechanisms has shown how in the presence of inflammation, even low infectious strains of virus is able to establish infection compared to if you didn't have inflammation, how the pH changes transforms what are commensal organisms in the genital tract to pathogenic organisms, and how that in turn is, and we don't know all the causes of what triggers inflammation. We're trying to understand that, but perhaps the most, the paper that I wanted to flag that's of relevance and significance in terms of preventing HIV infection is the high burden of HPV infection that we see in our populations. Already close to 2/3 by age 23 have HPV infection. Often it's with multiple strains. We've been able to understand longitudinally acquisition patterns and clearance patterns, and to see how new infection with HPV enhances HIV infection substantially. And what it does is, while we think about other interventions and so on, one of those that could be like a dual purpose is considering evaluation of HPV infection, one for HIV prevention, and two, which we know is the benefit of cervical cancer prevention. So if we think about HPV, we already have that. We're introducing it in South Africa at a much lower age range. So if we extend that and do a bit of catch up, Tian, you're frozen. You're either frozen or you're very still. So I'm just making sure.
No, I'm very much here. I'm very much here. Just to encourage you, colleagues, we've got 10 more minutes to hear from Prof. Abdool before we go into the Q&As. So please keep putting your questions and comments in the chat box. Thank you, colleagues.
Okay, so in terms of what, the two things to alert you to, we've described previously CAPRISA 256, which is a broadly neutralizing antibody isolated from one of our participants in the acute infection study. We isolated, generated sufficient quantities in the lab, tested it in non-human primates, and we just initiated the phase 1 trial a few weeks ago. And the phase 1 trial has multiple components. It includes safety, monitoring as a first-in-human trial. It's very atypical as trials go. We have most of these innovations happening outside of Africa, and then we are doing the testing in phase 2, 3. So actually generating a product that's locally informed and doing the first-in-human trials in Africa is actually a first, and we're really pleased so far. Everything seems to be fine. And that study, in addition to safety, is looking at dosing strategies and also combination strategies. And, you know, I think the broadly neutralizing antibodies, like antiretroviral treatment, may require combinations that target different components of the virus, and that's an idea that's growing, and that's what 256 and our work with CAPRISA 256 in the CAPRISA 012 trial is designed for. Secondly, we have the launch of CAPRISA 018, and CAPRISA 018 is an implant study where we've used the Jadel implant that's been widely used for contraceptive purposes, and we've inserted in it a more enhanced form of tenofovir called tenofovir alfenamide, and this trial was also launched a few weeks ago. It's also a safety dose escalation study. And the idea with 256 and with CAPRISA 012 and CAPRISA 018 with the implant and with the broadly neutralizing antibody is, can we have products that can be used 6 monthly or annually that can be effective for preventing infection? So as we know with trials, phase 1 is just the beginning, and it's really the phase 3 that will tell us whether it works or not. So we're early days at this point in time. So that's really the overview in terms of what we have underway, who, why, what. Yeah. On the prevention side, not the treatment. In terms of how has COVID-19 impacted the research, it's like everywhere else. You know, the first thing we had to think about was safety of participants and safety of staff. We put in a whole lot of risk mitigation measures and tried to be very creative in terms of participants who had already been exposed to investigational products in ensuring their safety. This included telephonic follow-ups. It included very restricted clinic visits that included like almost door-to-door service in terms of not exposing anyone. And as with everything else, nobody taking part in our trials, including and our staff, are immune to COVID-19. So we had to really ensure that we had all the protective, personal protective equipment in place for staff safety, and we instituted surveillance in staff with testing and those kinds of things. So there was the impact on research, and in terms of the other parts is about responding to COVID-19. And as you know, many people in CAPRISA are epidemiologists. Epidemiologists deal with epidemics. We don't run away from epidemics, we face it. And we, as with our HIV/TB research, it's not just the publications, but it's what impact are we having on policy and practice. And so tapping into that system, we've been playing advisory roles at different levels, the Ministerial Advisory Committee from the Department of Health, but also with WHO. I'm on the oversight committee for the therapeutics as well as for the proposed vaccine trials through WHO. We work very closely with Africa CDC, and we've also been contributing to the emerging literature. And I think with COVID-19, very new, and if we want knowledge and evidence-based approaches, we really have to be looking at how can we be contributing to that literature. And we've also initiated a whole lot of new research. We have to, in doing what we do, the sort of low-hanging fruit is what is the impact of COVID-19 on HIV and HIV/TB interactions, understanding epidemiology and transmission dynamics, understanding the small number of reinfections that we have, doing natural history studies. Is the natural history of infection different from other settings? And that's important both for therapeutic development and for vaccine development. So I'm going to move on in terms of other things, and maybe just to wrap up on this and then focus on the questions of what should advocates be doing. So one of the studies we're doing in CAPRISA is a study of reinfection. As you know, we had outbreaks in several hospitals early in March when the definition of who should be tested and the criteria for who should be having a SARS-CoV test was still very focused on international travelers and contacts of international travelers. We had a whole a lot of transmission that was occurring and seeding into the community because these individuals, although they were presenting with signs and symptoms of COVID-19, were not being tested. So by the time we got the definitions for testing sorted out, we investigated a few of these outbreaks. So we have some sequence virus from that period. And now there have been a few reports outside of South Africa of individuals who have been reinfected, and part of the testing was because they were very ill, and part of a differential diagnosis. Part of it was about policies in place in terms of returning travelers, etc. Long and short is we've seen now at least 6 or 7 cases of reinfection. That's very important because, you know, some of the thinking was, well, if you're infected with COVID-19, you have antibodies and you have protection. The reality is that we don't understand what protective immunity actually is. So when you have, by studying individuals who've been previously exposed and infected, and monitoring them to identify those who get infected again, we'll be able to compare the viral sequences, but also we now have more tools where we're able to monitor the antibody responses and neutralizing assays, so both binding and neutralizing antibodies and cellular immune responses. And so these studies will give us some good correlates of what actually constitutes protection, if indeed there is protection. And that's important to inform vaccine development and also in terms of therapeutics for COVID-19. So that's why I think that study is important. And I'm just going to stop there, and I'm happy to answer questions. And the two questions that you highlighted around what advocates should be doing. So I'll take that in the discussion. Thank you.
Great, thanks so much, Prof. Abdool Karim. That's really been an interesting overview. And I think especially in the context now of COVID, where the narrative has been so dominated by COVID-19 and less so to HIV and HIV prevention. So thank you for that. Prof, I wanted to speak about, so we have a few questions here. I'm not sure if you can still hear me. You're frozen. The screen has frozen. I'm not sure. Can participants still hear us?
I'm not sure why. Okay, I can hear you first.
Oh, okay. If you can hear us, then that's fine. So a question here from Grius Guman from the SANAC Civil Society Forum has been, the focus to date has been very much focused on those currently infected or measures to prevent infection. The community of COVID survivors are growing. Any ideas on what we should be doing to better support this group to sustain health and wellness?
Yeah, and I think that with the testing challenges that we've had, and I'm underscoring this because it's so centrally important to our response and an important advocacy point. So, so because we've had a shortage of reagents and test kits, we've not been able to test everybody who needs to be tested. But there's been a prioritization of those who are ill. And I think what's happened is that we are understanding better now. There's a viremic stage, and then there's an immune response when you look at illness and hospitalizations. And that most of the individuals during the viremic stage don't suffer severe disease, and very few require hospital admissions, etc. But it is that immune activation that's really is what's driving admissions in hospitals and the severe illness. And we're seeing with time and as these cohorts grow, that some people seem, not everybody has this very acute immune response, what they call the cytokine storm, that ends up, comes up about 3 weeks after symptom presentation, lands you in ICU. Some of the, so why do those individuals develop this severe immune response? It's like the body goes into overdrive. It does the right thing, which is your, exposed to the virus, it's fighting the virus, immune activation. But this very extreme manifestation is a real perplexing challenge for us. And it leads to people being in ICU, some people being very, very ill, and it's like a long, slow illness and very, very hard recovery. And so those individuals need a lot of support because it's not like they discharged from hospitals. Sometimes they're so severely ill. And what we have to understand is that this is infectious. We just from droplets, from being near people. So it's like spreads in the air, literally. And so families and people around somebody who's sick are at risk as well. And about 40 to 60% of individuals infected with COVID-19 are asymptomatic. So the kinds of messages that we can't move away from is all the simple things we have right now, which is the sanitizing. It's about the social distancing. It's about the mask wearing. It's about isolation. It's about quarantining. It's about understanding better the diversity of this epidemic. There is still a lot of stigma and discrimination. And I am humiliated every time I go to do my shopping. And even though the priority lanes for first responders and healthcare workers, that you go, people give you a wide berth and great, but it's really the stigma. And to me, first responders are supposed to be like the heroes out there. They're keeping the shops open so you can do your shopping. They're the ones delivering your food that you order online if you happen to be in that class and category of a living lifestyle. But the disrespect with which they are treated if they get sick, and almost like vectors of disease. And yet they at the coalface, whether it's about food production and sale and manufacturing, or whether it's about healthcare provision. So I think that stigma is something we know from HIV. And I am surprised still that I think part of it is a point I wanted to make about how do we move communities from anxiety to agency? And I think it's not just about sick people, but it's about all of our communities that are vulnerable. How do we impart knowledge? Knowledge that's correct, knowledge that empowers, knowledge that addresses all this anti-science and anti-vaxxer stuff there, to me is critically important. It doesn't differentiate between those who are infected and not infected. It makes all of us accountable and responsible of understanding that none of us have immunity, and even if we have been infected, we don't know. So not separating those who are sick from not, but really dealing with it, giving communities more agency and enabling them through knowledge and through resources and other ways and interventions. You know, it is that some people say, well, overcrowding. Some people say about lack of access to water. So it's the same intersection of issues we've been dealing with HIV. So not to separate HIV from COVID-19, not to separate non-communicable diseases from COVID-19, not to separate TB from COVID-19. And I think it's really, for me, an opportunity for us to take a more integrated approach. So if you want to protect people from COVID-19, you know, it's not age, it's age and comorbidities. And so obesity is like common. Diabetes. So don't wait, as we usually do, for people to arrive at health facilities. How do we start to increase this? How do we understand within our communities who are more vulnerable than others, and what are the things we should all be doing to mitigate that, one, infections, and two, the consequences of infections? Thanks.
Great, thank you. I'm going to ask you two questions now. So Wilfred is asking, given all the work you have done and other studies that have been done, would you say HIV prevention needs more operational research rather than clinical research to have a significant impact on HIV incidence in South Africa? And then if we could just take another one. Marinika here is asking, South Africa has been a lead with biomedical HIV prevention research in Africa. Are there capacity building plans wherein South Africa does a transfer capacity? So south-wise in terms of Africa, that sharing and really leveraging of all of the significant work that CAPRISA has done historically. So if you could address those two questions.
Sure. So it's true that that we have a lot of tools already available to prevent HIV infection. And there's a big gap between that evidence that we have and our ability to translate it to population level impact. And in fact, a lot of the UNAIDS new strategy that's been developed is about how it's innovating, it's what you have. But there remains gaps, and we do need a vaccine, we do need a cure, we do need to expand the prevention options, particularly for women, And, a lot of the new advances in PrEP delivery that are less user dependent are all weighing in towards transgendered women and men who have sex with men. We still continue to be lagging behind for young people. We still lag behind for women. We still lag behind for pregnant women. And so, what we're seeing is there's a disconnect between what is available and getting it to those who would benefit most. And that's our key populations, our most vulnerable, that don't utilize our health service facilities traditionally and typically. And I think, again, this is where advocacy is really important. And then the second is that we do need to continue to find new tools and technologies because there are important gaps. And so whether you're talking about injecting drug use, whether you're talking about sexual transmission, or you're looking at PMTCT, there are gaps in knowledge. And where we continue to see new infections, whether it's geospatially or in terms of venues, etc., it's quite related to human rights violations and restrictions of rights, either as individuals or in terms of HIV policies and practices. In terms of capacity building, it's something we have always, it's one of the goals in CAPRISA. We've done that through the Fogarty program. There've been a whole lot of initiatives through the Fogarty program, AfriHealth being one of those. And now with the establishment of the African CDC and also through the African Academy of Science, there are numerous initiatives on training and capacity building South-South. And I can say in CAPRISA, as I said, it is a priority, and we, as a self-funded organization, we can only do the training that we can with the funds that are available. And we've been establishing relationships in Nigeria through Alashle Abamiko, and then in Zambia, and also in Kenya. But these all take time, as we know, to build a critical mass. And I would argue, and as many people will tell you, there are so many clinical research sites in Africa. And my question is, why don't we have more African-led clinical research sites? Why are we not innovating? And we're collecting data, we're collecting specimens, and we think we're scientists. And that's something I think advocates need to be challenging, is why do we have pieces of the US and Europe in Africa running these clinical research sites, and we don't have Africans? The Africans who are there, and these sites have been there for at least 2, if not more decades. And in a way, we can't wait for things to happen. We also have to be architects of our own destiny. And if people take initiative, we will see change. If we're going to wait, we'll be waiting for another couple of decades, if not centuries.
Yeah, absolutely. I agree. I mean, I think decolonization of the space and addressing specifically the resource flows and our own accountability in country with our own spending on building that capacity and infrastructure certainly remains at the center. Prof, Oliver Meth is asking, in the context where information is constantly changing and being updated, what has your experience been, or what is the essential information for communities to know without adding to the noise? Have you seen any specific examples of this kind of communication that takes science to communities and cuts through the noise, the misinformation, the anti-vaxxer movement? Do any examples stand out to you?
Yeah, so I think people, there's a perception that everything is black and white, and we know everything as scientists. And the reality is that, and let me use COVID-19 as an example, is our knowledge is only provisional. And, when we first started to hear about COVID-19, it was described as a respiratory problem. Today we know it's a head-to-toe problem. So we say, there's a term and a phrase I use when I'm teaching students about COVID-19 is, we're building the ship as it sails. And so I think the more the public understands the scientific method and how provisional that knowledge is, and you know, you can have two schools of thought and action. So firstly, as an epidemiologist, I don't just understand, I have to act. So we have to act on provisional knowledge that we have. And some believe, well, you have to have every I dotted and T crossed before you act. Well, you have to balance saving lives with livelihoods and rights in action. And the thing with provisional knowledge is that you have to constantly update yourself on what's coming through. And you need to understand what's going on. And even though the publication may say X, you have to understand it locally and see if WHO does a guideline, which is a guideline, do we just follow that blindly because WHO said that? Or do we take local context into account? So that's what I mean about empowerment and we're knowledge empowerment. So if you understand what scientific method is and what your goal is and what you're trying to do, and the need to be, its knowledge is dynamic, epidemics are dynamic. And when you're trying to deal with this very dynamic situation at multiple levels, and at the same time, you know, COVID-19 is not like HIV. You know, with HIV, we have this long asymptomatic period, and then we got time to do a lot of things. And when people talk about warp speed, it's serious. I mean, you get exposed to SARS-CoV-2 within 2 days. You've got the viral replication, you've got signs and symptoms. Within 8 to 10 days, the viremia is over, your immune response is kicking in. So if you do a PCR like 14 days later, you may get a false positive result. So the diagnostic tests are important. A lot of the focus of diagnostic tests has been on PCR, identifying the virus. I'm arguing the viremia is not causing a lot of problems. It's identifying infections. It's part of a differential diagnosis and care, but we really have to understand the immune response better because that's where we're losing lives. That's where the deaths are occurring and so on. So, but we don't have antibody tests yet. Yeah. And where do antibody tests come in? In HIV, we know you develop antibodies, but the antibodies alone are not protective. And that's why we have HIV infection progressing to AIDS. Do we have the same thing for COVID-19? I really don't know. And with time, we're dealing with like a 6-month-old epidemic, and one that's come in, blasted itself in, I don't know how many countries across the globe, wreaked havoc. And then when you think you've seen the end of it, we're now seeing second waves. And not everybody is seeing second waves. Some people are seeing second waves that are in the midst of the first wave, and then severity of illness changing. So it just gives you some idea. Science is complex, it's slow, but you have to have the humility to know that you don't have all the answers, and you have to be able to share what you know with the understanding that this is provisional. In fact, I mark my documents. As of the 2nd of September, or what is it now, the 10th of September, this is what we know. Based on what we know, this is what we're doing. Because a week from now, it's going to be different. And when I come to you a week from now, it's, oh, what did you say? And this is what's creating fodder for anti-vaxxers and anti-scientists. This is science. This is how it's always been, and particularly health and human sciences. So that's not too different. How do we get that science method out there and enable people to be able to differentiate between what is hogwash and what is truth or factually correct, even as provisional as it is?
Yeah. Thanks for that. And I mean, I think we saw this as recently as yesterday with the Oxford trial. It blew up a fertile ground for anti-vaxxers, and they've certainly gone to town with that. And of course, the civil society, perpetually under-resourced, underfunded, is, you know, trying to step into that space to do some kind of response. I know we have exactly 5 minutes more left with you. I'm going to ask you to answer one question in 60 seconds, and then we can... Ntando is asking, can you speak to us about what we need to know about the second wave? You've already touched on it, but could you almost give us the headlines? What does this look like? How real it is? What is coming with the second wave?
Yeah. So Tando, that's a great question. I'm not sure I can do 60 seconds justice to it, but let me try. So, you know what, we're still continuing to see new infections in South Africa. Not as much as we did a little while ago, but we're now in level 2. And the public is interpreting level 2 is time to party. And so I walk around and I see no social distancing. I'm seeing large gatherings. I'm seeing no mask wearing. That's the recipe for the second wave. The second wave is in each of our hands. And if we don't do the Ubuntu, I am because of others. And I am doing this NPI for me and for people that are near and dear around me, whether they work colleagues or whether they my family and other loved ones and friends, etc. It is as simple as that. And if we do it together, that combination of things that we do, that if we have signs and symptoms, we're not exposing others to it. And this is where barrier protection comes in. So we can do it, we can mitigate it. But if we pretend level 2 means goodbye COVID-19, then we're just sticking our heads in the sand, and it's the ripe grounds for rapid spread of the virus. Now, we've had COVID-19 spread differently in the country. We don't understand completely why. Western Cape, then Eastern Cape and Gauteng, now KZN, and not very big epidemics in other provinces. So those places are likely to be places, if we're going to see a second wave coming, that we need to be monitoring in terms of hotspots and outbreaks and so on. And this is where my bugbear comes in about who gets tested, where we're testing, why we're testing. And if we continue to only focus on those who are being admitted to hospitals, if we only do via testing for virus and not for antibodies, and we pretend that if you've been infected, we got herd immunity, we don't even know that. So I think let's keep our eye on the ball and keep vigilant and use what we know in terms of the hand washing, social distance, and mask wearing.
Absolutely, thank you. I don't think we have a lot more time to address the rest of the questions, but we will get these questions to you and your team and hopefully get some answers to them. Elroy's really asking important questions about stigma. Yvette wants to speak about the responsibility of research. Veronica again addressing stigma and also speaking about the boldness of CAPRISA and its vision and its work. So having said that, thank you again. Prof. Abdool Karim, it's always a pleasure speaking. We hope this is the first. A lesson from today's call is that we certainly need to spend more time with you to flesh out some of these issues. So thank you again for making time and always being available to engage. We appreciate it and we wish you all the best in your work.
Thanks, Tian. And I think that my last parting comment is that as advocates, we have to work together, science and advocacy. And I think it's really important that as advocates, you do not feel disempowered, because the voices of the public, you know, I read the book by Judge, I'm blanking right now. Mokweng is that, not Mokweng, Moseneke, is that it's called All Rise. And it's not about all rise because the judge has entered the room. It is about the power that citizens have, which I think we constantly, I'm a citizen too. I happen to be a scientist, but I'm also a citizen. And I feel a lot of the time we underestimate the power we have. We saw it with HIV. We saw it with treatment access. And when new things come along, we kind of forget that. And I think instead of the silos, if we pull out, you know, talking about gender-based violence, talking about COVID, talking about HIV, talking about TB, talking about non-communicable diseases, we got to start joining the dots, because the underlying issues are the same. The vulnerabilities that drive all of this is the same. It is the structural issues. It is about the inequities. It's about the two tiers that we have of those who have and who do not. So the more we bring that development context into what we're doing, and the more we know that it's not about the resources, because as long as we're breathing and we have oxygen there, we can make a difference without money. And it's our pooled voices and energies that will take us to realize an aspiration that I don't think needs just to be an aspiration that can be realized. So thanks again, Tian, and thanks everyone.
Thanks so much, Prof. Karim.
Bye.
So colleagues, as we say goodbye to Prof. Abdool Karim, just a heads up, next week we speak to the leadership of the Bill and Melinda Gates Foundation, Dr. Solomon Zewdu, who's the Deputy Director for Health in Africa, and the Foundation's COVID-19 response lead. He'll be joined by Dr. Zamir Bray, the Senior Program Officer for the Foundation's TB work in South Africa, who will speak to us about the specific work that the Foundation is undertaking and supporting in the country. On that note, colleagues, thank you again for your support and your participation. And we look forward to welcoming you and everybody else next week when we chat to the Gates Foundation, which is certainly going to be an exciting discussion that we will have. So thank you again for joining everybody, and have a great Thursday. See you next week.